Shall we begin?
Your voice is still breaking.
Hello? Mrinmay, can you check if I'm audible? Yes.
Samita, I can't hear you. Can you hear me? Can you just put it in the chat box where you can hear me? Hello? Okay, great.
A very good evening to our respected speaker and members of the audience. It is my pleasure to welcome you all for today's event. Before we begin, I would like to brief the audience about Ascension. Ascension is the annual Medical Humanities Conference conducted by the students of St. J.S. Medical College and KEM Hospital under the aegis of Dr.M.V.L.Kothari, Chair of Medical Humanities. As a part of Ascension, we are organizing panel discussions, interactive sessions and orations consisting of eminent panelists and guest speakers with huge experience and knowledge in their respective fields. Ascension aims to encourage students to think beyond academics. This year, the conference revolves around the theme COVID and mental health as a cultural memory. As a part of this today, we will be talking about healthcare in India, but not hospital-centric, but something beyond it in a much more micro level. On this note, I would like to introduce our speaker, Dr. Yogesh Kalkonde, sir. MD Medicine, MSc in Clinical Investigation USA, MD in Neurology in USA. He is a public health doctor, researcher, advocate, and also a neurologist. He is trained in medicine, neurology, neuroimmunology, and clinical research in the United States. He has 20 years of experience in working on micro to macro aspects of health. 10 years ago, he left his job in the US to work with tribal and rural communities that have limited access to healthcare. Until recently, he worked at Search, a non-governmental organization in Gadchiroli, Maharashtra, where he led the chronic non-communicable diseases research and tribal health programs and was also a joint director. He also participated in the rural hospital of Search. He has recently started working in rural and tribal areas of northern Chhattisgarh. He is the recipient of the DBT Wellcome Trust Fellowship in Public Health and the Bruce Schonberg International Award in Neuroepidemiology by the American Academy of Neurology. He serves as an expert member on several committees of the Indian Council of Medical Research. He has also published close to 50 research papers in the international and national journals, including the prestigious journals like the Lancet, Lancet Global Health, and Stroke. He also serves on the editorial boards of national and international journals. Welcome, sir. Before we begin, I would like the audience to keep their mics off and mute. If you would like to ask any questions in between, you are welcome, but please raise your hands and wait for your turn to speak. Also, you can put your questions in the chat box and our team will be taking them up at the end of the meeting. Over to you, sir.
Thank you, Samhita. Is everybody able to hear? I see a message from Dr. Nadkarni that she can't hear. So is everyone able to hear me?
Yes, sir.
Yes, yes.
Okay, so it seems like there is some problem. I can't hear the others, but a good thing that I can be heard. So first of all, I would like to thank the Kothari Department of Medical Humanities at KEM GS8 Medical College and KEM Hospital for this wonderful initiative of Ascension, where we sort of try and open the horizons of medical students. Typically, we are sort of trained in medical colleges as monotaskers who focus on procedures and simple diagnosis and treatment. So a great initiative, and the department has taken a lead. So and thanks a lot for this kind invitation. And so what I'm going to do is, although this is an oration, what I'm trying to do is I'm going to share my own story as to how I understood about healthcare outside hospitals. So I'll start my presentation. Can everybody see it?
Yes, sir.
Okay. So what I would do is, as I said, I'll share my story. So the question is how I started learning about healthcare beyond hospitals, and the credit of that goes to Preventive and Social Medicine department and my interest in preventive and social medicine. And it started with a short note in MBBS final examination, and that short note was on iceberg phenomenon. And some of you who have gone through the final MBBS and have trained in preventive and social medicine can relate to that. And I had this habit of drawing diagrams in the papers and use them to explain a concept. And I was very fascinated by this concept of iceberg phenomenon. So I ended up drawing a figure in my exams, which looks something like this. So, probably I drew a diagram which was much too elaborate than this. But in the process, what happened was I ended up writing so much on iceberg phenomenon, which was a short note, that I had very little time to address a long question. And the end result was that I barely passed in preventive and social medicine. But this sort of, this concept really fascinated me, that, when we are practicing in the hospitals, what we see is really the tip of the real health picture of the community, of the country. And in that way, we, just as clinicians, become a bit myopic unless we engage with the community. So I trained subsequently in medicine, and one of the things that I wanted to do at that time, we all go, through periods of confusion after MBBS, and one picture that sort of sent shudders down my spine was this picture, that I didn't want to do what everyone else is doing, and I wanted to do something different. And what was the thing that I wanted to do different? And I wanted to address health, but my interests were sort of diagonally opposite. My one interest was in immunology as a basic science, and I thought it holds a promise of improving human health. And going through the pandemic, we can all attest to it that what the vaccines are doing, and vaccines are the product of research in immunology. And my other interest was public health, which actually takes you to people, understanding people's health problems and working with them to solve public health problems. So there's one interest that is taking me to laboratory far away from community, and the other was in public health. So this was a traction between two interests that I had. And like everyone has after a phase in MBBS, and there's always confusion. So whether I should go this way, that way, or another way. So what I decided to do is I said that I have a choice. So if I really want to look into immunology, the best way to do that is work in it and spend some time and then take a call. So I went to SGPGI Lucknow, where I trained in the Department of Clinical Immunology, where I transitioned to started working in laboratory and not seeing patients. Then I went to National Institute of Immunology in Delhi, and then this journey took me to a place called University of Texas Health Science Center in San Antonio. And I loved what I was doing, and I was working on the role of molecules called chemokines in brain, and I was working on non-chemotactic role of chemokines in the brain. And this was absolutely fascinating. I was working on a phenomenon of social recognition and social memory in mice, and trying to figure out what are the molecules involved in that whole process. And I thought that I'm settled for my life until an expensive experiment sort of derailed me. And I was supposed to purify a set of proteins using some protein purification columns. And it was expensive. The columns costed $2,000. And I went through the process. And what I realized was at the end of this procedure, nothing came out. So in a span of 4 hours, I sort of spent $2,000. And then the physician inside me started, asking questions to myself, like, is this something that you should do as a physician trained in India? Do you have the right to sort of just chase your dreams and be away from people, while the $2,000, which at that time translated into 1 lakh rupees, could have been used to spare maybe 100, 300, 400 lives? And so the answer from inside was no. I think the answer came in that maybe I should use my research to help people who need it the most. And so that incident took me back to India, and I decided to come back and work with rural communities using my research skills. And so I was working at this place called Baylor College of Medicine in Houston, Texas, which is one of the most largest medical centers in the world. And then I came to Gadchiroli. So it was a quite interesting transition, coming from a very heavy tertiary medical center to a place where even getting primary care was an ordeal. And this is the place. And Gadchiroli is one of the most underdeveloped districts of India. It has a population of about 1 million. About 40% of the population is tribal, and 90% of the population is rural. And physician to population ratio is 1:5,000. So for every 5,000 people, there is one physician, as against 1:1,300 in India, and as against 1:600 in the United States. So suddenly, I moved into a resource restrained or resource constrained setting. And then when I started practicing there in the rural hospital of Surge, I suddenly realized that I'm just a doctor. So people were not fascinated by that I being a neurologist. And actually, the first patient I saw was a 3-day-old baby who was continuously crying. So in a way, this was sort of interesting, because you feel that you are trained in a highly specialized area, and what are you doing? But the different way of looking at it is, I started looking at it as being useful to the community. So is a neurologist more useful to the community, or is an MBBS doctor or MD medicine doctor is being useful to the community? So it was a fantastic feeling that, by despecializing myself, I have been useful to a lot many people than someone with a specialist. And this also raises an interesting question that whether specialties should empower you or disempower you. So, I thought that specialty was my tool. I could use it whenever it's needed, but that should not enslave me into doing one particular thing. So, I became doctor and started understanding issues of rural and tribal health. Although I was trained about 200 kilometers north of Gadchiroli in my MBBS and MD, the rural realities, the tribal realities were hardly known to me. And so, and all these individual cases helped me, understand healthcare and its challenges in India. So I'll tell the story of this 21-year-old girl, a tribal girl who visited her village. She was doing BA in Gadchiroli. And in tribal areas, there is a custom that women, move to a menstrual hut when they are menstruating. So she moved to that menstrual hut. And at midnight, she felt, some tingling in her feet and maybe a little pain. And by morning, she realized that she is unable to move. And it was good that her mother came to check on her at 5 a.m. in the morning and suddenly found that her daughter is unable to move. And so they started, procedures to get her to the hospital. And the whole village did not have a motorcycle. So her father goes and waits for a bus at the bus stand. And there are about 2 to 3 buses in the whole day. And he's fortunate, he gets the first bus, goes to the next village where he has a relative, and gets a motorcycle from there and puts her in the motorbike, and using the sandwich method, which we saw, where there is a driver, then there's a patient, and then there's someone holding the patient. And she was brought to the hospital. And by the time she came in, she already had neuroparalysis. So this was a case of crate bite. And she could barely breathe. So we had to put her on ventilator, and she came out. Fortunately, she reached hospital on time, so she could be saved. And I see Dr. Dr. Bhaviskar is here, so he would attest to all these, snake bites and the challenges in managing snake bites. He's a pioneer in management of snake bites. So I started thinking, so what were the challenges for her in seeking healthcare? So one was cultural customs. So this custom of, having menstrual hurt put her at risk of having a snake bite. Then there were maybe many times there are gender issues, like, women are not provided treatment as prompt as men. And there are issues of transportation, which we all face, but we never think of it as a part of healthcare. These problems started, bothering me, because it's very hard to see a young female or a young lady dying because of snake bite. And the challenges she posed, I mean, if this would have been 2 hours late, she would not have made it. And then there was another interesting thing that, tribal people would say is that they will plead not to send them to the district hospital. And this was quite hard, because district hospital was the only, sort of secondary or tertiary center in the entire district. And they would beg me. I had a patient who was quite sick, and I said, you need dialysis and you need to go to the district hospital and maybe to Nagpur for further care. And he said, please don't send us to district hospital. They do not treat us well. So there was an issue of, treating patient well, treating patients as humans, treating patient with dignity. And our system is not able to provide them that basic dignity, and they're discriminated against. And so I was as a clinician, this was, the first thing that I could quickly do. But again, as I said, my interest was whether I could use my research skills to improve the health of the community. So I started venturing into the community. And so this is a picture from what we call a non-tribal village in Gadchiroli. And this is a hamlet in tribal area. And after visiting these places, I started wondering what would be the health priorities of these places. I mean, just by looking at it, you can say that, is this hypertension, diabetes, stroke, ischemic heart disease phenotype, or is this more like pneumonia, diarrhea, malaria, filaria phenotype? And so, as doctors, we are trained to make certain guesses. And I thought that, I would know the health priorities of this area. It's quite straightforward that, people will be dying in this area of diarrhea, pneumonia, malaria, and snake bites. So the question is, like, how do I find this out as to what are the priorities of the community? I mean, I'm trained to see individual patient and diagnose individual patient, and suddenly my canvas and my role is changed from individuals doctors to communities doctor. And so there are ways of diagnosing and treating individual patient. There are interesting ways of diagnosing and treating an entire community. And so one of those interesting ways is figuring out what people die of. And this is a quote by Simone de Beauvoir. She says that you do not die from being born, nor from having lived, nor from old age. You die from something. And if you can figure out what people are dying from, you can actually get a sense as to what are the health priorities of the communities. There are other methods of diagnosing communities using community-based surveys, talking to people, and understanding their health concerns. So we wanted to understand what are people dying from in Gadchiroli. The question is, most of the deaths occur at home in rural India. So how do we figure out how? I mean, there is no medical certification of cause of death. So how do we figure that out? And so for that, we resorted to a method called verbal autopsies, and I call it stories that people tell. So a person dies, but he leaves certain information which can be used by a health system to actually diagnose a community and develop methods of addressing it. And how does it look like? So I'll give you an example of a verbal autopsy which has a narration. And this is a narration from a verbal autopsy which says Rajaram was 52 years old, would always use tobacco. A lump developed in his mouth and kept on growing. He showed to a local doctor, but did not heal. The lump burst and there was an ulcer. He found it hard to eat food and grew weaker. And he was bedridden and eventually stopped eating and passed away. So this person would have died at home, and I would not have known what has happened to him because we are busy in the hospitals. But this narration actually provides you a reasonably good sense as to what this problem was. And even I would say even the first MBBS student, if he reads it, he can say that this is probably oral cancer. So it's not a perfect method, but it does give you a reasonable sense of what is happening in the community. And this method has been used in India since 1960s, also in developing countries since 1960s, to figure out what is happening in the community. And again, as I said, as physicians, we only see a very tip of the iceberg. We don't see what is happening in the community. So what we did is we looked at analysis of all causes of death between April 2011 and March 2013 using verbal autopsies. So in these three clusters in Gadchiroli, we recorded every death, and on every death, a verbal autopsy was filled. And when we looked at the results, we were really shocked. So what you see here in this pie diagram is on the left side, there is unclear diagnosis. And this happens because, Gadchiroli is really underdeveloped. So people would just have symptoms and they are never diagnosed. And then others, it is the right side. But was stroke the leading cause. And again, as I showed you the pictures of tribal and rural villages, and looking at them, one would not imagine that stroke has emerged as a healthcare priority in the district. And the next leading cause of death were tuberculosis, which is expected. And then you see cancers, then you see ischemic heart disease, then you also have diarrheal diseases, malaria, and injuries and external causes of death, which include suicides, contributed to almost 10% of all deaths. So this is a fascinating pie chart. And for someone working in community, this is like sakshatkar. The community is revealing itself to you regarding what its health priorities are. So I was so, it surprised me completely. It, shook me out of my slumber, thinking that infections are the leading cause of death. And, it's beautiful because it revealed truth, what is happening in the community. And we published this in the journal Stroke. And what it shows that when we look at the entire population, it also gives you certain numbers of rates. And what we found that there were 190 deaths per 1 lakh population per year in this particular region. And if you extrapolate this to Gadchiroli, so Gadchiroli has a population of 10 lakhs, so 10 times 190. So 1900 deaths were occurring in Gadchiroli district every year due to stroke. And that's a large number. 1900 deaths is a huge number. So when we looked at where people died because of stroke, and you can see that 93% of women and 82% of men died at home. So again, as I said, like when you work in rural area, what you see in the clinic or hospital is a very, very, very incomplete picture of what is happening in the community. And you can see that more men were taken to hospital or more men died in the hospital compared to women, again, highlighting the gender issues in healthcare in this particular region. So again, as I said, one thing was, it revealed stroke as the leading cause of death. And it was serendipity that I'm trained as a neurologist. So stroke comes right up my alley regarding management. But what bothered me is, why is this happening? Is this really true that, stroke is a leading cause of death? And so one of the ways to explain this was a phenomenon called as epidemiological transition, meaning that communities are not static. Like we grow, we are child and we are youth and we are sort of middle-aged and we age. So we are dynamic, like a patient is dynamic. Communities are also dynamic, they are static. So, and this particular data are from England and Wales, and you can see from 1860 to 1960, how pattern of causes of death changed. So you can see that initially infections contributed to close to 50% of death before 1860, and then they gradually, infectious deaths due to infectious diseases declined over time, and that indicates a socioeconomic progress. So when the socioeconomic status is changing, the disease entities and what are the leading causes of death also change. But then that raised a question to me is, like, if this is happening in Gadchiroli at the community level, what is happening in the rest of the India? Like, what people are dying of in the rest of the India? And one of the challenges, again, in India is over 3/4 of deaths in India occur at home. So, this was back in 2006, and the situation could have slightly improved by now. But still, a large chunk of people die at home. So we really, as a country, there is a lot of challenge figuring out what people died of stroke. And then these are data from, representative data for India using verbal autopsies for year 2010 to 13. And this is a very long procedure at the national level. And we all saw that during the COVID deaths, that it was not easy to count COVID deaths. And a lot of COVID deaths were undercounted because, many people did not go to hospital at all. They died at home. And so verbal autopsy helps to, take a sample from the entire nation, and then you can look at the causes of death. And what is interesting is, now, almost a quarter of deaths now occur because of cardiovascular diseases. And cardiovascular diseases have become leading cause of death, while infections, which are on the left side, which include malaria, tuberculosis, respiratory infection, diarrhea, and so forth, contribute about 15 to 20%. So even at the level of India, the epidemiological transition has occurred. meaning that now cardiovascular diseases are going to be the leading cause of death. But again, as I said, that only gives you incomplete picture. We don't know what is happening at the level of the community in terms of morbidity. So what we are seeing here is the data on mortality. But we can look at data from morbidity, and India conducts large surveys called National Sample Survey. And this is the data from the most recent sample survey, where a sample from the community was taken, and the surveyors went to the community and asked people what are the conditions for which you sought care in a given period. And you can see that infections still dominate when it comes to outpatient care, especially in the rural area. But urban area, you can see that infections have gone down, which is again shows a transition down the spectrum in the epidemiological transition. But you can see that cardiovascular and endocrine disorders are now sort of becoming a major cause of seeking care. And then the big question becomes, where are people going to seek care? And working in the rural area, this becomes a very important question, because care is not easily available. I mean, in Mumbai, you step out and you would have maybe 10 hospitals within a span of 10 kilometers. In Gadchiroli, you might have to travel 50 kilometers to reach a decent hospital, or maybe more. For tertiary level care, the nearest place for people from Gadchiroli is Nagpur, which is 200 kilometers. So this becomes an important question, where people are seeking care. And what you see is that, predominantly care in India is sought from private sector. So 2/3 of outpatient consultations are done in private sector, while government system provides about 30%. Then we look at hospitalizations, and hospitalizations, these data are sort of familiar to us because we work in hospital. So you see almost sort of, equal chunks of cardiovascular diseases, gastrointestinal diseases, respiratory diseases, genitourinary diseases, so on and so forth. But again, you see that infection is an important cause of, hospitalization in India. Although you can see that the chunk is sort of, the chunk is smaller when it comes to urban area. That data is not here, but I'm just showing data from males and females. Then the big question again is, where do people get if they need to get hospitalized? And again, private sector plays a big chunk, big role in this. And 55% of all hospitalizations occur in private sector, while government and public hospitals contribute to 42%. And this is, India-wide data. If you go to rural places, the government systems are, is where the care is predominantly sought from. So if you go to rural area, almost 50% of hospitalizations would be in a government hospital, because obviously the cost that is involved in private hospitalization. And at the level of India, we also know what is the average expenditure on each hospitalization. So if you go to government hospital, if you get admitted in government hospital, the average expenditure would be about 4,500. And if hospitalizations occur in private hospital, it's almost 8 times higher. And so overall expenditure on healthcare will be about 20,000 rupees, which is a whopping amount if you're looking at incomes in rural areas of the country. And so again, it's like, where do people get money to, if they have to pay for hospitalization? And these again are data from NSSO. And 80% of the expenditure actually comes from household income and saving. About 13% have to borrow in rural area, which puts a lot of financial stress on them. And then there is hardly, there is any insurance which actually provides monetary or financial protection against expenses due to hospitalization. And then this leads to, in the language of public health, something called as catastrophic health expenditure, meaning that where more than 10% of families' income is spent on hospitalization, it's called as catastrophic health expenditure. And the burden of catastrophic health expenditure is very high in India, with close to 20% of the households incurring catastrophic health expenditure because of hospitalization or health-related expenses. So this is a massive, massive burden. And if you look at healthcare resources in India, we see that the population per 1,000 population in India is 0.9 as against Thailand. Thailand, I've compared India with Thailand because Thailand has a very well evolved healthcare system, and actually it delivers much better results than what we see in India. And that is because of something called as universal health coverage, meaning that everyone gets insurance in Thailand. So you can see that the physicians are 0.9. In Thailand, it's almost the same. If you go to countries like UK and US, then this number would be about 2.6 to 2.8 physicians every 1,000 population. If you look at nurses and midwives, it is recommended that there should be at least 3 times more nurses and midwives compared to physicians. So that number should have been 3 for India, but it's only 1.7. Thailand, it's a good number because you see that it's more than 3 times the number of doctors. If you look at hospital beds, again, India lags behind compared to Thailand. And there is something called as Universal Healthcare Index, which means how much population is protected by insurance coverage. And India gets a score of 55 as against Thailand, which is score of 80. So overall, largely our health systems are still struggling. So what I learned when I sort of started studying what is happening at the level of India in terms of healthcare delivery, I realized that now cardiovascular diseases have become leading cause of death and outpatient consultation. And this is based on community level data and not what is happening in the hospitals. Care seeking is predominantly from the private sector. Healthcare resources in general are limited in India, so we need to do better on healthcare resources. And we also know that those numbers are skewed because in India, 60% of healthcare resources are in cities, while 30% healthcare resources, when it includes hospital beds, doctors and nurses, only 30% are in rural India, while the population of rural India is 66%. So I call it 60-40 paradox, where 60% of population lives in rural area, but only 40% or less than 40% of healthcare resources are available in rural areas. And healthcare expenditure is many folds higher in private sector, and people are not protected against financial hardships. And patients have to bear the burden of healthcare expenditure. And I saw in Gadchiroli that people, if people don't have 10,000 or 20,000, they will prefer to die. And this is rather heart-wrenching that people dying for 5, 10, 20,000 rupees. So the situation is far from great, and there's a lot of work that needs to be done. So this was a very sobering picture of what is happening at the level of when it comes to healthcare system and healthcare delivery in India. So going back to Gadchiroli, so we have identified stroke as a problem, and so we are trying to figure out how do we solve this problem. And when we looked at population level data, we conducted population level survey and saw patients with stroke and looked at them, how many are taking antihypertensive medications. So about 40% were taking antihypertensive medications, while from other survey, we knew that close to 65% of patients with stroke have high blood pressure. We know that we can prevent stroke using antiplatelet medicines, which are very cheap, like aspirin, or you can use statins to prevent stroke. And 10% or less patients of stroke, diagnosed stroke, were taking these medications. So overall, a very, very dismal picture of secondary prevention. Then we looked at, what people think about stroke. So we conducted qualitative studies where we talked to people. One of the very interesting methods in public health is just go and ask people what they think about it. And there is a scientific method which evolves around these discussions, and these are called focus group discussions. So we talk to people and ask them, what do you think causes stroke? And different themes came out, and what were those themes? Unclear cause. Some people said it's the destiny that causes stroke. Some people say, based on the concept of Ayurveda, that there is increased vata in the body. Some people said now food had changed significantly. Earlier we used to eat hand-pounded rice. Now we eat machine-polished rice. Some people said it's linked to cold weather, stress. Some people said that blood goes bad. And very few could recognize that this is a disease of blood vessel. And then we asked them, do you think strokes can be prevented? And their answer was, we cannot predict whether we are going to suffer from stroke. Then how can we prevent it? So essentially, community is not aware regarding what is stroke. Stroke for them is a sort of a new disease which has occurred, and there are no easy explanations because nobody has gone and told them what are the risk factors for stroke. And it is when we sit in OPDs and when we ask patients, and then we very easily label them as ignorant. But on our part, we have never taken efforts to sort of educate them in the language they understand by simplifying the concepts. So again, at the community level, there was significant lack of understanding regarding mechanisms of stroke. And stroke actually, brought a lot of hardships to the family, as said by this female individual. Participant of the FGD, that whole family gets disturbed. If earning male of a family suffers from stroke, then the wife's life becomes hell. She may have to earn the bread by working as a laborer in forest. She will spend on treatment as much as she can afford. She will take suggestions from the other people regarding treatment. So she will do as much treatment as possible, but after a limit, she will let her husband die. And this causes significant disruption in the family. I have had patients who had stroke and survived. And, now there is no breadwinner. The lady has to work. the patient had 2 daughters to be married, and marriage in rural area, especially girls, is an absolutely challenging task. So this actually posed a cognitive challenge for us. Like, can we solve this public health problem? So stroke has emerged as a public health problem, and can we think of methods by which we can, we can sort of solve this problem? So, but the challenges were like this. So, if strokes are the leading cause of death, there is only one neurologist in the entire district. There was only one CT scanner which was available in the government hospital, and half of the time it was closed. So I would say only 0.5 CT scanner in the entire district. There was no facilities for giving clot buster drug, TPA, like we give streptokinase in acute myocardial infarction. There are very few hospitals. Forget about neuro-intensive care where stroke patients can be treated. And the patient have challenges accessing hospitals as well. So on this background, one could say that this is a hopeless situation. You should not even think of stroke and let the situation progress as it is. But that was not an option. So what we did is we designed a community-based intervention where we thought that we cannot treat stroke in this setup. Acute stroke treatment is not possible, but we can certainly prevent stroke. And stroke, and that way, is a highly preventable disease. And high blood pressure, treatment of diabetes, reducing risk of recurrent stroke by giving statins and aspirin is an option. So what we did is we said that we have to come out with an intervention that is not very heavy on doctors. So what we did is we trained community health workers. These are village women with at least seventh grade education. And we trained them to measure blood pressure using a digital blood pressure monitor. And so what we are creating here is we are creating a resource in the village. So until then, they didn't have this resource. They had to rely on community. They had to rely on going to hospitals. And now we are, training a lady who can go and measure blood pressure. And so these community health workers went and measured blood pressure of everyone above the age of 50. And this particular lady was very happy because she must be 65 or 70. She couldn't tell her age. But for the first time in her life, someone has ever measured her weight, blood pressure, height, and urine sugar. So, again, as I said, healthcare remains way too away from people. And so we realize that people have difficulty accessing healthcare. Coming to, hospital is a challenge, especially for women patients, because they have to depend on their husband or son, and who might not prioritize their health condition. So they're always low priority when it comes to taking them to the hospital. So we said that let's let the doctor go to the village. So we started a mobile unit in these intervention villages where the doctor went in and checked patients who were screened. So the entire village was screened for people above the age of 50 for hypertension, diabetes, and stroke. And then these patients were referred to this visiting clinic, and medicines were provided free to them. And then community health workers followed up with patients, making sure that they're taking their blood pressure well, they're taking blood pressure medicines well, and or if they had diabetes, they ensured that medicines were regularly taken. And then we created health awareness material. As I said, there's the awareness material is typically in English, and nobody simplifies it for rural folks. So we really simplified what causes stroke, and had community awareness sessions. We also collaborated with IIT Bombay to develop state-of-the-art animation, which in very simple language explains stroke. And this is freely available on YouTube. So if any one of you are interested, you can take a look. And while doing this, there were some larger questions regarding healthcare that came to my mind. And so we say that we are healthcare professionals. So essentially, that should involve health plus care. And you can always ask questions. So are we really sort of dealing with health, or are we dealing with diseases? And care component is, again, we can always question ourselves how caring we are and how much care can we provide. And so the big question is, what is health? And some of you who have gone, almost finished your medical training might have come across this definition of WHO, which defines health as a state of complete physical, mental, social well-being, and not merely absence of disease or infirmity. And so are we really dealing with health? We are essentially dealing with disease or infirmity. And the next definition of health, which is even more audacious and much more imaginative, and this is surprisingly given by Sushruta. And Sushruta says health is a state of equilibrium where fundamental physiological governing principles of the body are in equilibrium, and the metabolic and digestive processes are in equilibrium. The principles that uphold the formation of body tissues is in equilibrium. Waste products are excreted well, and Ayurveda, sort of stresses heavily on removal of waste. And the fantastic thing, the sense organs, mind and soul are in a state of bliss. So it's much more wider and much more positive definition than just social well-being. So it's fantastic definition. And the question becomes, are we really sort of focusing on health of people, or are we just dealing with the disease? And a crude realization came to me that actually, so once health ends, diseases starts, and that's where people come to hospitals. So actually, we are sort of, we are disease treaters. We are not really able to reach to community and improve their health. So we indirectly help in their health. If they have life-threatening condition, if we end up saving them, then they go back to the community, and so their health gets better. But a very large chunk of health actually lies in the community outside hospitals. And again, as I said, that the key question is: are we healthcare providers, or we are just disease treaters? And when I ask that question to myself, I see that I'm largely a disease treater. And the larger question is, who is responsible for health? And so, is the doctor responsible for health? Is the patient responsible for health? Or an individual who's not sick is responsible for health? And the other question is, do doctors themselves take good care of their health? The costs go up and the benefits actually go down. So if your interventions are at the bottom of the pyramid, the benefits are higher. So and when we try and specialize, we actually start going away and away from health, and we start treating more and more diseases and more difficult conditions, and we take pride in treating those disease conditions. But from a larger healthcare perspective, it is the cost-benefit ratio is not that good at the top of the pyramid. So to summarize, a lot of healthcare action actually occurs outside hospital. And again, if we had to revisit the first diagram that I showed regarding iceberg phenomenon, we only see tip of the iceberg. We need comprehensive, preventive, curative approaches to improve communities' health. And hospitals may not be necessarily the answer, but working at the community level, improving, primary prevention can give you big, returns. Medical needs, system needs to be strengthened to provide high quality care. We need to not only focus on giving care, but focus on giving high quality evidence-based care. Then universal health coverage is needed to reduce out-of-pocket expenditure. So the Ayushman Bharat program of the government is actually a first step in that direction, where, if they are covered by insurance, the catastrophic healthcare expenditures go down. And eventually we will also have to, work with people, because they are not passive bystanders. Usually the way things happen in India is, people get sick and then they are just passive bystanders, and doctors take control of everything, while it should be actually a partnership process. And doctors should also work to actually make sure that communities are healthy. And in the first place, people do not get sick. So we need to actually go outside, step outside the hospital and build capacity of the community to take care of its own health issues. And Gandhiji has used a very interesting word called Swaraj. So when everyone was defining Indian independence as freedom, Gandhiji called Swaraj. Swaraj is self-rule. So instead of, freedom gives you a sense of liberty, but not responsibility, while Swaraj actually highlights the responsibility of every individual regarding maintaining her or his health. So with that, I'll stop and I'll acknowledge my young buddies at Surge who were actually involved in running this trial. I showed some of the interventions in the trial. The trial data are being analyzed, and we hope that in the next 1 to 2 months, we'll be submitting it for publication. And what we found was, interesting results regarding effect of such simple community-based intervention on stroke deaths. And I would like to thank Welcome Trust DBT India Alliance for funding support. And last but not the least, people of 86 villages in our service area in Gadchiroli. So thank you. Thank you very much for your kind attention.
So we have 2 questions in the chat box right now. So one of them is...
I can't hear you. No, I'm still, the voice is breaking quite a bit. So let me just try and re-log in. Will that be okay? Samita, can you just type your answer in the chat box? So I'm looking at the chat box. So one question I see is my views on strengthening our primary healthcare centers in India and role of general practitioners in community, including big clinics. So fantastic question. So so primary healthcare is actually key to addressing health systems challenges. So if your country has a really good primary care, then its dependence on secondary and tertiary level care can go down significantly. So for example, if we have to prevent strokes or heart attacks, then it would be best to have a primary doctor at the primary health center who actually helps diagnose hypertension and manages well using simple management algorithms. So managing hypertension and diabetes, at least a majority of patients, is not rocket science. It's quite easy. And if you have simple protocols, those can be used by a physician. And even there is now research in public health area where simple nurse practitioners or even nurses can use those protocols to actually treat hypertension and MD medicine physician to treat all the hypertension and diabetes in the country. We just don't have enough MD medicine physician. We don't even have enough doctors to actually treat hypertension and diabetes, because India has close to 277 million patients with hypertension. So about 20 crore patients with hypertension. So we have to sort of assign lot and lot responsibilities to primary healthcare. This is something called as task sharing in the lingo of public health. So we have to share tasks. We have to empower our primary health system to better handle simple things, so that those who are at the tertiary health center can actually handle much more challenging situations. So, and any country which has a good general practitioner system tends to do well. And the example for that is not United States. United States is actually heavily focused on the higher level of care. They don't have proper insurance system, and there is no emphasis on primary health care. While countries like UK, United Kingdom, and Scandinavian countries have a lot of emphasis on primary level care and family medicine and or general practitioners. And they tend to, their health indicators are much better compared to United States. United States actually, I spent 10 years of my life in the United States, and United States, states spend 17% of their GDP on healthcare. And still their healthcare indicators are not better than Scandinavian countries, which tend to spend about 10 to 12%. So, strategically spent healthcare resources is very important. And for that, we really need to sort of highlight the role of primary healthcare and, general clinical care. So that is answering first two questions. Then there are questions, how to understand, emphasize, and help problems of tribal rural people. And this is a question from Biplab. So fantastic question. First thing is, we need to recognize that 60% of India's population is rural, 66 to be precise, based on the census data on 2011. So you cannot improve country's health indicators if you are ignoring 66% of the population. And so, we have to take rural health care very, very seriously, and we have to address this as a real challenge. In tribal communities, they have a lot of challenges. The healthcare scenario in these areas. And The way we understand is by using national surveys. I mean, if you are interested in looking at it as to what the rural indicators are, look at, the NSSO data I showed, the National Sample Survey, 75th round. And you would see very nice, I presented a few data just to get you interested, but if you're interested, just look at the data, and it's fascinating. And I think we should also learn these in medical colleges, other than, just, learning to treat individual disease condition. Then the next question is, we tend to impose our perception of health on people in rural areas. Fantastic question. That is very, very true. The usual approach that we have is very hierarchical. We think that, we are doctors, so we are sort of next to God, and we know everything. And even, the word that I often hear in medical conversations is, nahi, that, ye to dehati log hai, anpad hai, gawar hai, or they're ignorant. Even in medical literature, you see this word ignorant. So, ignorant, we are also ignorant of, what situation they are facing. So the ignorance is mutual. So that needs to be, changed. We need to understand how rural people think. And I presented a qualitative study that we conducted on stroke, just to highlight this, as we need to understand how patients think. Unless you understand how patients think, you cannot really solve the problem. And lifestyle issues. So all this younger generation has to take lifestyle issues very, very, very seriously. And, you can lead by example. So, start taking care of your own health. So, and then maybe we can take one or two questions. So there is this question from Junaid. There is misbelief regarding allopathy, especially in rural population. When we have resources to help them, sometimes they don't accept it, leading to damage that could have been easily avoided. How to handle such scenario? So one thing is, again, the answer to that is engage with the community. So if you have read what is happening regarding vaccine hesitancy in rural areas, people came out with proper solutions. There is a way you have to engage community, you have to engage community leaders, you have to work with them. And once the community leaders are convinced, they can easily convince the other people. So in districts, rural tribal districts where this could work, that actually helped them save. The other thing is information. They have a lot of, now in rural areas, you have equal amount of information or maybe small amount of information. And by creating awareness in the languages they understand, by taking, talking to their elders or leaders in the community and recording their own statements regarding, whether, why they should take vaccines. So coming to the example of vaccines. Then the other question is by Jerry. She says, sir, how can young medical graduates contribute to improve health and care scenario of the country, especially in rural areas? So first thing is there should be an interest to do that. One thing is this young generation is especially creative. So you can create material to increase awareness. And for that, you have to go to community. So the first step is actually start going to rural communities whenever you get a chance. If you are from rural area, then in your vacations, go to rural area, visit a primary healthcare center, see how the system works, and come out with a solution. And again, as a large problem I found was that there is not adequate awareness material which is entertaining and informative in local languages. And India has so many local languages, even local dialects. So we need a lot of awareness material. So young students can work on that. First thing would be to actually just go in rural area and spend some time so that you understand what are the challenges. And solutions can emerge. There are a lot of trainings that occur. So community health workers need to be trained. So you can certainly help with your own community medicine department to engage with rural population and create awareness material. Go spend time with them. Do simple things. Again, as I said, like very simple things make a huge difference. So, for example, it's a big thing. That Sputnik boxes are not available. You go to the community, use your imagination. And again, as I said, you guys are very tech savvy. You can find technological solutions. Then one more maybe. Is it possible that other forms of medicine like homeopathy and Ayurveda acts as a complement to allopathy when the resources are limited? See, I'm not an expert in homeopathy and Ayurveda, but WHO considers homeopathy as not a pathy, not a science. Ayurveda, I'm not particularly interested, sort of enamored by the treatments, but what fascinates me about Ayurveda is its heavy emphasis on prevention. So if one thing we have to learn from Ayurveda is very heavy emphasis on prevention. And as the definition of Sushruta shows that, it's much more imaginative, audacious than that of WHO. So if you ask me what we should learn is